joining us faculty, and Sunil sir will be joining us facilitator later in the session. So I'm over to Sinia for the faculty introduction. Sinia.
Good evening, all. A warm welcome to the first session of Integrated Basic and Advanced Course in Palliative Medicine. Today, we are going to have our first session, that is on Introduction to Palliative Care. We do have Dr. Sanghamitra Bora joined here with us. Our facilitator, Dr. Sunil Kumar MM, will be joining with us later. So I would like to welcome Dr. Sanghamitra ma'am.
Not audible at all.
Sanghamitra ma'am, am I audible clearly? Can you please confirm?
Yes, I can hear you.
Thank you, ma'am. Thank you for confirming.
Yeah.
I would like to introduce Dr. Sanghamitra ma'am. She's associated with Assam Cancer Care Foundation for the past few years, and she has completed her MSc in Palliative Medicine from Cardiff University, UK in 2017. She's a volunteer of Urgewin Healthcare Foundation and an active IAPC National Faculty since 2010. And she's also a national trainer for National Health System Resource Center and a very active member of various palliative care association and a close friend of Pallium India. Welcome again, ma'am. Welcome back, and over to you.
Thank you, Senior. It's, as always, it's very, very good to be taking, interactive sessions for Pallium India. And because I have a selfish, intention of learning with trying to share knowledge. So whatever is in my capacity, I'll try to do my best. And I hope everybody out here who has joined us today, will be benefited. And having said this, I always urge people to go back and, try to look at the literature and find out more facts and details about the topic that is being discussed. So we'll just start with my presentation. Kindly let me know if it is visible to all of you. I'm sharing my screen here. Is that visible?
It is visible, ma'am. Please go to the presentation mode.
Sure. I hope it's okay now.
Yes, but now please go on.
Okay, so introducing palliative care, I think, will be now a little obsolete slowly, because I'm absolutely sure that everyone who is here today, knows a lot about palliative care. So that's a kind of a challenge to me. But having said this, I'll try to do something about the quality of life, the kind of interactions that we do with patients who are terminally ill, their families. So WHO actually gave this particular definition to palliative care way back. And recently they have also come up with modifications. Many world organizations like the IAHPC, the AHPM, the APHN, everybody have their own experiences of delivering palliative care for patients. And they have come up with more suggestions on what should be included in the definition of palliative care. But then the gist of the whole thing remains the same. It is improving the quality of life of patients and their families. And these particular set of patients are generally suffering from life-threatening illnesses. The basic, intervention that we as palliative care people do is aimed at preventing and relieving the suffering of such patients by means of early identification and impeccable assessment. Okay. treatment of pain, basically, and associated problems like other physical problems, psychological problems, social problems, spiritual problems. These things are actually adjunct to the basic relief of suffering. So this is the palliative care definition. I would suggest that you also, try to find out other palliative care definitions that are given by other organizations, and you can go on adding to it. Maybe many of you might already be working with palliative care setups, or individuals who are working in palliative care setups, and I would really urge you to ask their kind of their research, or their take on what palliative care is. There is a modern concept of palliative care, and you all must have heard about Dame Cicely Saunders. So Dame Cicely Saunders was a palliative care nurse in the UK. She developed herself as a palliative care specialist, as a physician, and then she did a lot of pioneering work for palliative care, giving it a modern concept, of palliative care. So the model of care is applicable across a range of life-limiting and life-threatening illnesses. For example, cancer, and many other specific diseases related to the cardiovascular system, the respiratory system, neurological diseases, etc. As of now, we recognize palliative care as an international human right. So, little bit about how it developed in India. What is the context that we are talking about, and where do we stand as of now? So this is a kind of a timeline, and this particular slide, I have actually taken this picture from the Indian Journal of Surgical Oncology, where the study has been very nicely elaborated, and this gives us a beautiful timeline from comparing the international development to that of India. The green dots are the timeline of India as compared to that of international timeline. As you can see, in the 12th to 20th centuries, the concept of hospice developed internationally, and hospice, as as the word says, was a kind of a place where the travelers used to rest. Okay, for example, there were pilgrims who used to go from basically suffering from some kind of disease, which was not, they were not getting better with the disease. So they used to take a pilgrimage to the highest order of their religion. And they used to, seek solace, going to that particular place of worship and praying that they or their loved one who is suffering from that disease should be cured of that disease, or the suffering should be, it should be curbed. So on the way, because there was, the transportation was not developed, people had to walk a lot, maybe use bullock carts or other horse carts, etc., to travel from one place to the other. They used to go, and there were other people who cared for such travelers, and they used to make certain places where they could rest, they could spend the night in that particular place. So those places later on, came to be known as hospices because of the fact that many such travelers were actually suffering from disease. They were patients. And, there were certain instances where such travelers used to stay in those hospices and were unable to complete their journey to that particular pilgrimage, and they used to die in that particular hospice. So the concept of hospice came out in the 12th to 28th centuries, and this was a place where people who were traveling for pilgrimages used to die. So that is a hospice. And then Dame Cicely Saunders came out with, the modern concept of palliative care, and she developed the St. Christopher's Hospice in UK in 1967. And then, internationally, if we see, the US was a little late to develop palliative care, and they started with a hospice called the Connecticut Hospice in 1974. But then, how did the palliative care thing come into India? So the National Cancer Control Program actually triggered the palliative care movement in India. So in 1975, we had the National Cancer Control Program. There were, in tidbits, there were development of certain small organizations led by NGOs and other things, individuals who were working for cancer patients, and they wanted to develop something related to pain relief and etc. And they were working with cancer patients. So within the next few 9 to 8 years, around 1984, the cancer control program was actually modified, and they included pain relief as a basic service at the PHC level. The PHC is the primary health center, which is now modified to other a different name altogether. So the trigger was actually the National Cancer Control Program, and it took almost 8 to 9 years to include pain relief, which is a very important part of cancer care and palliative care, to be included in the modified National Cancer Control Program. Then you can actually see how rapidly it has been developing as compared to the international developments. 1986, Shanti Avedna Ashram, which is a pioneer in hospice care in India, was started, and it was started in Mumbai. It also has a unit or a branch in Delhi as of now, and it was also developed within the same time. But then 1990, a very important organization was formed, which is the Cancer Relief India. It was started by again a UK nurse, Gilly Byrne, and Gilly Byrne actually researched throughout India. She brought out a paper which actually which actually gave us the whole scenario of where are the gaps in palliative care in India. So Cancer Relief India was a pioneer, and then Dr. Rajagopal actually started Pallium India in 2003, and before Pallium India came in, the neighborhood network in palliative care was started in one in Kerala, with the Indian Association of Palliative Care forming in 1994. I'm just giving a retrospective from 2003 because Dr. Rajagopal was a student of Gilly Byrne. That is an interesting thing. And Gilly still comes to India and goes around, the states of India. But then the seed that was sown by Gilly was actually leading to so many other branches of a huge tree. Okay, so Pallium India was started in 2003, and the Kerala palliative care policy was adopted by the government of Kerala in 2008. So Dr. Rajagopal and his associates have a lot of contribution in bringing in the Kerala state policy. Okay, and that is where the whole blueprint of the neighborhood networks of palliative care and the home-based palliative care services and an internationally acclaimed palliative care organization was started. Maharashtra then followed the state policy in 2012, and thankfully the national program in palliative care was started in 2013. And after the forming the national palliative program in palliative care, immediately the NDPS amendment was done. And that was a game changer altogether because opioids were then easily available for our patients, and then followed by, other proper agendas like the Pune Declaration and many other things that have been going on since then. So this is in a very brief thing that I have told you about the development of palliative care in India. But the point that you should note out here is regarding the National Program in Palliative Care and then the NDPS Amendment Act. So coming to basically, what do we look for when we practice palliative care? What is it that triggers that palliative care consciousness in us? What is it? So I generally give an example of differentiating between what is a disease and what is the illness. So you can see there is this particular patient. He has a big, wound. You can also perhaps see the tongue inside his oral cavity. It is visible here. He has a Ryle's tube. This man is just 42 years old, but I think he looks around 60 or 62. He has a cheek cancer. It's a head and neck cancer. It's very common in the Northeast. And he lives with his wife and his two children. Both the children are very small. One is 9 years, another one is 5 years. He comes to the OPD with pain and a foul smelling wound. Okay. So now, for me, for a physician, the disease is the oral cancer and squamous cell carcinoma of the cheek. Okay. That is a scientific thing that I'm saying. And then perhaps a superadded bacterial infection which has happened on the particular wound, right? So for me, for an oncologist or for a doctor, this is the disease. And we are focusing on the disease itself so that, it's cured, or, we can actually get rid of this particular wound that has happened to this patient. But what is the illness? The illness is, everything that I've told you, plus the pain that the patient is suffering. Perhaps he's not letting you know also that he's suffering from this pain. Perhaps he is just hiding many things. For example, he's losing his weight because of poor appetite. He's always tired. He's concerned about the disfigurement that has happened to his body. He's also concerned about the foul smelling wound that is always oozing, the saliva and the other debris that is over the wound. It's being oozing all together. He has been socially alienated. Why? Because people think it is a taboo that this man has a disease. He has done some. He has been cursed. That's the reason why he is having this problem. His children are alienated by other children because their parents tell them not to play with them. Okay. They can't go to school also because they don't have the money to go to school. The whole house, the whole family of these few people, they are engaged in looking after this particular patient at home, because of which all the resources that they have, the limited resources that they have, are diverted towards the treatment of this particular patient. Okay. And what is this patient thinking? What will happen to my family? I'm the sole breadwinner. If I die tomorrow, who is going to fetch my children? Who is going to pay for their education? Okay. And the question, why did God do this to me, is something that, comes to anybody's mind if, at the slightest of disturbance. For example, if you plan a holiday tomorrow and for some reason it gets cancelled. For example, during the COVID times, you never knew that there would be a lockdown. Okay. You never knew that there would be a lockdown, and you have actually booked your tickets 6 months before. You have actually paid the airlines, you've booked the hotel, and then the lockdown happens. There are rise in COVID cases. You cannot travel international or national even. And the whole thing is a flop. Okay. You would actually question God, why have you done this to me? I mean, I would have gone to holidays, enjoyed a lot, and come back. After that, we could have done this. Okay. So the question of unfulfillment of someone's wishes, or the question of why this is happening to me, is absolutely natural. It happens in any kind of situation that you face. So this particular situation is the illness, right? So palliative care generally looks at the illness. There are many more facets, there are many more aspects to this, but basically when we talk about palliative care approach, we need to see the illness that the patient is suffering. And the illness is always the disease plus the psychosocial, physical, spiritual issues that the patient has. So why do we need to, understand illness? Because we want to understand in depth what is happening to him, what kind of suffering this patient is going through. The New England Journal of Medicine in 1982 actually came up with this very beautiful definition of understanding suffering. And it says that it is a state of severe distress associated with events that threaten the intactness of the person, and occurs when an impending destruction of the person is perceived. It continues until the threat of disintegration has passed, or until the integrity of the person can be restored in some other manner. Okay, so this particular definition actually is self-explanatory. When you go through this definition, every time you read this definition, you understand different meanings that you can actually come up with every point that it has said. For example, severe distress associated with events that threaten the intactness of the person. Can you imagine what might have hampered the intactness of a person? When you look at this particular patient that we had just discussed about, the intactness can be, his bodily disfigurement. The intactness could be, the social alienation that he and his children are facing. That intactness could be related to the threatening of his monetary benefits. Okay, so everything that comes to a person and makes the person intact, that particular intactness, when it is threatened, that leads to suffering. And that is where we have to understand what kind of suffering this patient is having. So it is a property of the whole person and not a phenomena that can be reduced to part of a person. Okay, and this means that we just cannot see only the disease. Okay, when we say part of the person, it means perhaps looking at only the disease of the person and not actually going beyond and looking at the illness of that particular person. So very interestingly, it is said that pain is a common cause of suffering, like many other causes. And, a severe headache will actually lead the whole person to suffer. You have a severe headache, you are going to perhaps a marriage party, a marriage reception. You are, properly dressed, you look beautiful, but then because of the headache, you are unable to concentrate on what is happening outside your environment. Okay, you are not able to participate in anything. So that actually, causes a person to suffer. Okay, and because of this, people who are accompanying you, your husband or your wife, your children, they all are concerned that you are having a headache, because of which you are trying to go back soon. They are not able to enjoy the whole dinner or the reception. So when you look at life in this particular angle, you can actually bring about a lot of things, a lot of angles where suffering can be related. So this was just a small practical example that I had given. But then when you understand the suffering of a palliative patient who's terminally ill, there would be many things that you will need to understand. So basically, when we want to understand suffering, we will also need to, delineate what are the goals of care. Okay, so definitely alleviating suffering. We will need to optimize the quality of life of this particular patient till death, and of course beyond death also. And then provision of comfort in life that is going on and in death also. So persistent and inadequately relieve suffering will undermine the value of life for the sufferer. Alleviating suffering is universally acknowledged as a cardinal goal of medical care. So, unfortunately, this is not nowadays not done. But then suffering is universally and has to be universally acknowledged as a cardinal goal of medical care. And the ability to recognize suffering, my friends, is always an acquired skill. You have to practice, how how you recognize. You have to find your own checklist. You have to draw your own boundaries, or, a scale of your own, where that through this, I'm going to understand the suffering of my patients. And this is going to be a skill, through practice. You'll need to practice always. You'll have to interact with patients. You'll have to interact with people who take care of patients, their family, their friends, even your colleagues in the hospital, the nurse who's always taking care of a patient there, maybe the ward boy, or maybe the ward girl, So take inputs from all the people working in such palliative care setups, working with patients who are terminally ill, and, practice your own thing and find out the scale for yourself. So this is an old concept. You can see it is absolutely simple. So there is a diagnosis of this disease, which is life-threatening or terminal disease. Then you start with a kind of a life-prolonging therapy. For example, the cancer, if it is a terminal cancer patient, then you start, with a curative intent for this patient. And when you start with the curative intent of this patient, at one point of time, maybe the whole idea of putting this patient through this particular therapy has not worked. And you see that the therapy has failed. The cancer is increasing. The patient is actually getting terminal slowly. And at one point of time, there has to be initiation of end of life care, and maybe some bit of palliative care, and then death. So this is an old concept where very little time is given for palliative care interventions or even end of life care interventions, and there is no care after death. There is no cure beyond care beyond death. So this old concept was then brought about, turned around for a modern concept where life prolonging therapies and palliative care generally would start right at the point of diagnosis of this of any life threatening illness. And as time crosses, if there is a point where the life prolonging therapy or the curative therapies have actually stabilized the patient, the need for palliative care would also come to a halt. Okay, but then as the disease progresses and there's very little room for life prolonging therapies to give this patient a ray of hope for cure, the palliative care therapies or the palliative care treatment or the palliative care approach would actually take a much bigger role, will play a much bigger role in the treatment of this particular patient. And then, of course, at one point of time, maybe the conventional palliative care approach will not work for this patient. You may then understand that, yes, the patient is actually coming towards the end of life, and hence we will need to initiate the end of life care. End of life care would be a very sophisticated yet simple kind of a therapy or simple kind of an approach for such patients till there is till actually death overcomes the patient. And that doesn't really end our responsibilities. We also extend bereavement support to the family who's left behind. So this particular concept is actually a modern concept of palliative care. And the gist that you must know, the point is that it starts with life prolonging or curative treatment, and it starts from the point of diagnosis, and it extends beyond death as bereavement care also. So there are three great clinical skills in medicine, that are diagnosis, treatment, and prognosis. But the modern medicine is more focused on diagnosis and treatment. Okay. Prognosis have actually, over the last 100 years, it has given way to treatment as the core clinical skill accompanying the diagnosis. We generally do not want to prognosticate. Okay. Why? Because we know that once we say that the prognosis is poor, the patient may not like it. Okay. So we want to say, as modern physicians or modern healthcare system, we want to give, at every cost, we want to give the patient life. All right. We are generally not telling them the prognosis. But fortunately for palliative care, prognostication is one important skill that is going to give the best of care for our patients. So I'll come to this point, why we are doing prognostication in palliative care. Why is it important? I'm sure you'll, in further classes, where you are going to learn more about prognostication, but I really wanted to share at least 2 or 3 slides in prognostication here, because prognostication in palliative care holds a very important place. Okay. So prognosis basically is a prediction of possible future outcomes of a treatment or a disease course based on medical knowledge and experience. Now, because of the uncertainty of the future and the complex dynamic system of the human body, prognostication can seem mysterious, unknowable, and powerful. Through applying scientific method, medicine has and can make advancements in predicting medical outcomes despite the formidable task. So this, has been given way back in 1999, and this generally gives us a tool through which we can advance the future outcomes of a treatment or a disease. So why do we want to prognosticate? Because we want to provide the patients and their families with information, and that should be the right kind of information, so that they can set their goals, they can set their priorities, and they can also set right expectations of care from the medical team. We also want to help these patients develop insights into their dying. Okay. There should not be any kind of darkness between communication with the patient and the family. Okay, the patient has to know crystal clear what is happening to him, whether the patient is a child or whether the patient is a adult or whether the patient is educated, uneducated, doesn't matter at all. The patient must develop correct insight into their dying process. Thirdly, we also want to assist the clinicians into their decision making. Okay, not every clinician can be expected to take the palliative care approach, but when palliative care physicians or the palliative care team is there, it can actually help these particular clinicians or these particular primary oncologist or the primary nephrology team or the respiratory medical team to take their decision, the correct kind of a decision, and not just beat around the bush. Okay. Fourthly, we have to help them compare like patients with regard to their outcomes. All right. And last but not the least, to provide a common language for the healthcare professionals involved in the end of life care. So every professional who are involved in end of life care, it may be the doctor, it may be the oncologist, maybe the nursing team, maybe those involved in cleaning up the patient, the ward boy who is working in the end of life care ward, the ward girls, everybody in this particular team will have a common language. When I say common language, they all know that the patient has little time to live. They all know what kind of care this patient is going through. They all know what to tell the family members when they are around. Okay, so this is actually helped only when we are skilled at prognosticating our patients. Okay, so Fries and Ehrlich, way back in 1981, actually gave us 5 Ds of prognostication, and these are the disease progression or recurrence, deaths, disability, drug toxicity, dollar cost. Dollar cost is the the cost. So examples are like, for disease progression of recurrence, what is the median survival of a patient with colon cancer who has liver metastasis? If you ask this particular question to yourself, when you have a patient with liver cancer developing liver metastasis, if you know the answer, okay, if you have researched other patients who may have suffered colon cancer, how much they have lived with liver metastasis, you can actually prognosticate this particular patient's survival. When it comes to death, what are the future problems will this patient have with advanced oropharyngeal cancer and dysphagia? If I put the patient with a gastrostomy tube, okay. So disability, will this patient with a cord compression walk again? Will he become disabled? Can I actually reverse the disability if he already has started with a cord compression? Toxicity, mostly we use opioids, and opioids, as you learn further, induces nausea. So the question of how long will this opioid-induced nausea last? This is an example of drug toxicity. And then the cost, will it cost more to manage this patient's pain according to the recommended guidelines? Okay, so everything taken together, if you remember the 5 Ds of prognostication, you can actually pinpoint how much the patient is going to live, what will be the course of illness or course of the disease of this patient. And my friend, nobody will be able to question your actions taken together for this particular patient. So please do go through this. It's very important in palliative care. So these are certain factors you can actually keep on adding to it. I'm not going into much details, but then coming to a very specific concept of total pain, because we do not generally only see physical pain, it's the total pain or total suffering. I'm sure many of you may have already seen this slides in different formats altogether in many other presentations, because it's very, very common now. I'm not going into detail, but then, when we talk about total pain, we have to look for a overall suffering of the patient. It might be physical, spiritual, emotional, social. You can actually go on adding many other dimensions to this particular concept. These are a few of my patients over the years that I've seen. I remember their names. I also remember what disease they had suffered. This is because of the fact that, when I was involved in their care process, they had made a significant difference to my personality. This is a 20-year-old boy. This was a 20-year-old boy. He looks like in his 50s, maybe, with a very, cauliflower growth, as you can see. So, as you practice palliative care, you actually become a very sensitive and very apt individual, because you want to help these patients, maybe they have been left or abandoned by their families. It might have also happened that they no longer seek any kind of help from anyone, because of the fact that they do not get help when they seek it. Okay, so these are certain sensitive issues that will cross you in your career, in your professional life, and you will at one point of time try to personalize things like that, and emotionally get bound to patients. I'm sure all of you who are there present in today's session will have had certain experiences that that actually doesn't go off from your psyche, from your mind, and that actually gives you a thought for finding newer avenues or newer options of how to help patients if you get another one with a similar condition. So all said and done, palliative care is active medicine. We do not sit with the patient and cry, as many people might think. Many of my doctor colleagues have actually told me, oh, you are in such a psychologically demeaning, depressing kind of depressing kind of a thing. Why have you been doing this? This doesn't pay you off well. But when I look back retrospectively, what I have been doing all these years, I know that I have been actively practicing medicine, and it has actually prompted me to read, practice the actual medicine that I've learned in MBBS and in my post. So that is something very important that we all must understand as professionals, whether we are doctors, whether we are nurses, whether we are volunteers, we need to practice active medicine. There is nothing like sitting and holding hands and crying with the patient. We are helping the patient in curbing physical symptoms. We are scientifically evaluating the spiritual issues and the physical issues also. And we are trying to give them that particular solace, that particular solution to their problems. So talking about issues, physical symptoms are a tip of the iceberg. This is an iceberg, and you can see so many other issues are actually deep behind, deep under this a person's physical symptoms. Once you take care of the physical symptoms like pain, you actually the emotional, sexual issues, spiritual issues, broken relationships, all these issues actually start surfacing out once you take care of the physical symptoms. So always give heed to physical symptoms. The psychologist will not be able to help any patient with tremendous pain. The pain needs to be taken care of. The wound needs to be dressed. The maggots needs to be taken out, and then only the patient will actually come up with so many emotional and other social issues. So implications of palliative care in serious illnesses like cancer. And this is not my data, it is what the reports have said. And they say that the current cancer prevalence in India is 2.5 million. I'm giving you a data which is of 2012-2014 PBCR report. The next report, which is due, it will actually explode to another level, I'm sure. But right now, current cancer prevalence is 2.5 million, and new cancer patients registered annually is 0.9 million. So you can actually imagine what is going to happen in the next 30-40 years. India actually sees deaths due to cancer almost 0.5 million. 2/3 of our cancer patients generally always present in stage 3 and 4, which are advanced cancer, and they invariably will need palliative care. So this is the implication of cancer. You see an aging population. I remember one of these very big political rallies that had happened in Delhi. When Mr. Modi was sworn in as the prime minister, and he used to actually scream at the top of his voice that "Ye to young India hai, ye to young India hai." But then, perhaps he never imagined that we also are going to have an aging population, which is actually increasing manifold day by day. And as of now, it has 100 million elderly at present, expected to increase by 324 million by 2050. Okay, where I am also included because I'm already crossed 50. So by 2050, I'll be, I don't know how much. So, we all will age at one point of time, and it is soon going to happen. So 60% of the elderly population are affected by cancer, and rest 40% have other comorbidities. All right. And those serious diseases we also will need palliative care. There is always a problem of unrelieved suffering. There is a undertreated cancer pain in India of almost 1 million people. Only 0.4% of our patients with cancer pain have an access to oral morphine. I hope, with the other reports coming in the future, perhaps the 0.4% will actually increase a little, because we already have the NDPS Act that has been modified, and you will in your other classes, specific classes related to morphine and opioid availability, will come to know about the latest reports also. But then unfortunately, pain is one thing that is really, really being undertreated in India. Would be many people who generally do not really understand how to treat pain. Okay, you will have to practice relieving pain and relieving suffering. You'll need to practice a lot. All right, it's been 20 years that I've been practicing palliative care. I still learn new things, new methods, new aspects of dealing with pain, because such a subjective symptom, such a subjective agenda of people, every patient will actually teach you something when you treat that particular patient. You'll find new facets, new faces of pain altogether. Fortunately, we have had good people, who have worked towards social reforms, towards drug availability. One such article that I would really appreciate if you would go through is this particular one, Civil Society Driven Drug Policy Reform for Health and Human Welfare. And many stalwarts have actually come together to write it. Please do go through it, and you will actually come to know so many other so many other aspects that as a civil society we need to understand regarding drug policies, regarding availability of morphine, etc. So present Indian scenario, already talked about the National Program of Palliative Care. I'm not going much into details. And of course, the NDPS Act. NDPS Act was, the old act was in 1985, has been now enforced as the new 2014 version, which actually gave a lot of power to the single window officer, which is the drugs controller of a state. And this has made easy access to oral morphine, especially oral morphine. If you are interested to pursue a career, we have the MD in palliative medicine. We also have the DNB in palliative medicine now. Lot of private hospitals and many government hospitals have started with palliative medicine. Pallium India has been running fellowship and certificate courses also. I was, I'm proud to say that I was a student of Dr. Rajgopal in 2009, and since then I haven't looked back. And Pallium India and Dr. Rajgopal sir has also been behind my back to push me more into doing palliative care and working for our patients. If you are volunteers, if you know any person who wants to do a course in volunteering in community palliative care, etc., many other organizations run proper courses for volunteers also. So the big question is, how we want to die. Do we want to be surrounded by certain pipes and tubes and oxygen masks and strangers, or do we want to die like this particular lady, where her daughter is actually perhaps, I have taken this from Pallium India's website, and this picture speaks a lot about what a patient needs at the end of life. So I come to the end of my presentation today. I hope I've been able to deliver up to your expectations. And I always get, very, very inspired by this particular proverb. It's an African proverb, and it says, you think you're too small to make a difference, then you have obviously never slept in the same room as a mosquito. So, if you are a small mosquito and you think that you are very small, you can't bring about a difference, then you are wrong. Because once the lights are off and the mosquito starts biting that person is actually bound to get out of the bed and switch on the light. So this is very inspirational for me and many like us. I hope I have come to something that I am able to inspire you also. Please keep on working in palliative care, and I am really thankful to Pallium India for giving me this opportunity to start off this course with the introduction to palliative care. So thank you so much. I am just stopping my screen share, and I'm ready to take on questions if you have any. Thank you so much.
Good evening, everybody. I'm Dr. Sunil Kumar. I'm the Additional Director of Toronto Institute of Palliative Sciences. Am I audible, Senior? Senior?
Yes, sir,
Am
you
I
are
audible?
but the hub is muted, I guess. Senior, can you
Sorry?
please check? Sir, you are audible, sir.
Yes, sir, you're audible.
Okay. So, thank you for joining us today, everybody. Do you have any questions to Sanghamitra?
Yes, sir.
Yeah.
Good evening, sir. I'm Dr. Swati Mishra. I'm from Mumbai.
Yeah.
I actually really want to know, like ma'am said that people ask her that it's a depressing specialty, but is it really? Because, the thought of death and end of life care. So is it really depressing for the physician, and how do you cope with it? Because there's so many aspects to this. It's not just seeing a patient and giving treatment. It's much more than that. So how do you cope with it as a
Sanghamitra,
physician?
you are on mute, Sanghamitra. Please unmute.
Sorry for that. Thank you, Dr. Swati, for this very interesting question. You see, when I'm talking about my experience, okay? So when I first joined palliative care, and it was a whole ocean of things that I was interacting with. I had new things every day to learn, and so that gave me a lot of kind of invisible powers to practice, okay, as a doctor, because I knew how to manage pain. I knew that I have to take care of the social aspects. I also knew that, there are spiritual things involved. So this was very overwhelming. Overwhelming because I wanted to give a solution to everything. All right. And that was a very wrong thing that I had developed. You have to delegate things to your colleagues. So do not take everything on yourself, number one. Number two, do not really think that you can provide solution to all the things. If you start doing that, you will definitely be depressed. And you will know that it's going to be depressive because I can't do this. मुझे ये नहीं करना आता, मैंने ये solution नहीं दिया. Patient तो आज रो रो के गया है. Patient की बीवी रो रही थी, उसकी माँ रो रही थी. You will actually see everything that you're not able to provide. All right. So it's important that you set your boundaries, number one. Number two, you delegate your problems to other team members. That is the reason why we work in teams in palliative care. There are unfortunate incidences or unfortunate instances where you are the only person in the whole team. You have started as a sole practitioner model, but then it's important that you set your boundaries. Do not try to give solution to every problem. Listen to that particular person, listen to that patient, what he has to say. Listening is a skill that you have to develop by any means in palliative care. You absorb everything. Okay, you absorb everything the patient says. That might be the only solution you can provide to the patient at that point of time. But having said this, we always follow the rule that correct the correctable. Whatever you are able to correct, please go ahead and correct. And whatever you're not able to correct, first accept that I am not able to do it, so I can't do it. When you accept your faults, when you accept that you are not able to do it, you have already set your boundary. And so you do not go beyond that. So that is going to help you. It is very obvious that when we fail to meet the expectations of patients, it becomes depressing for us. And that is where our colleagues generally tell us that it's very depressing. So they have to understand, which they still don't, unless and until they go through palliative care trainings. And, yes, that is it. So I'm sure there are self-care classes lined up for all of you. That's my answer. Thank you for the question.
So, shall I give another perspective
Sure,
to what you have asked? I completely agree with Sanghamitra, and you asked about many things, even though it is a single question. End of life care, then self-care, then many other things. But literacy, depression, who are working in palliative care. So the important thing is that, yes, we see a lot of patients who has serious suffering. It is not only the patients, it includes the families also. But what you have to understand is, usually we look at the disease. So we do not see the suffering with the patient. So patient might have some carcinoma, cancer or something else, but we see only cancer. We do not see the pain, the psychological problems with the patient, the lack of money with the patient for doing chemotherapy. And there are a lot more. So what happens is, or we might be blind to see that. So when as a palliative care physician or palliative care professional working in the setting, everybody is trained to look at the total pain of the patient. So it is naturally, everybody will have, they will be affected. But uh, it is also true that after the patient comes to palliative care, then most of the patients would have very good symptom control. The patients who reach us crying or in severe depression or very sad, they start smiling at us. Probably if you do the symptom control, and next day morning when you go for rounds, they would be smiling at you. And the next question that they are going to ask us, doctor, can you cure this disease? That's the next question they are going to ask you. So it is true that there is distress for the patient that we have to look into, but we see a lot of smile, and that's what we actually wanted to see. So these things make us stay back in palliative care. And actually, as a person, when I joined in palliative care, within maybe 1 week, in the first week of my life in palliative care, the concept, uh, 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 the stress. I thought this is a specialty which doesn't require much skills or knowledge or things like that. But within 1 week, I understood that this is the specialty which requires more skills, more knowledge, and self-care. All these things came into me automatically. So, yeah,
Thank you, sir.
thank you.
Thank you so much.
Good evening, ma'am.
I think,
Yeah, sorry, ma'am. I would like to ask you one question. Ma'am, what are the challenges you faced as a practicing palliative care physician?
Lot of challenges. The biggest challenge that I still face, is from my fellow colleagues who are in oncology. So generally, they don't want to actually leave the patient. They don't want to start palliative care at the point of diagnosis. That is because of the fact that maybe they have a misconception, or they understand palliative care still as an end of life care. So that is where I do not get referrals of my patients at the point of time when they should be referred. So that is a big challenge, and I think it has been there since quite some time, and it's going to be there, because oncologists and specific specialty physicians, they go through a lot of crucial training. They are very much disease focused, and they should be, of course, because they are the ones who is actually going to help the patient get rid of the disease. uh, but having said this, I sincerely feel that the integrated approach of specialty palliative care and the specific disease focused care should be should be coming very soon. I mean, it is we and them working together for this such patients altogether. Otherwise, we will always be in the end of life care era, or end of life care situation, and there'll be very little that will be able to bring about, little difference that will be able to bring about. This is the biggest challenge that I as a physician have faced, and I still face. But having said this, I think once you start showing your receptiveness to your fellow doctors, they understand the importance of your contributions. I am with my organization since the last 5 years, and slowly referrals have started. And, I think they have now slowly started to understand why this is important. So I think, yes, that is the biggest challenge.
I think Dr. Bipin has some questions to
Yes,
ask.
thank you. Thank you for letting me into. Ma'am, is this a feeling that we, I mean, in developing countries have this issue of oncologists trying to keep their patients with them? Or this is a thing that you have an experience in the developed nations or the countries with kind of fully insured healthcare expenditure that we often see. Most of our patients who are unaffording, I mean, not afford much of a palliative care in sense, because the part of the globe that I am working at, when I see that patients even cannot afford a wound dressing, even if they go to a private setup. Thank you.
Thank you, Dr. Bipin. Actually, you're right. It's this particular issue is not only in India; it's outside also. But the difference that we see for Indian patients and patients abroad is that the government has actually taken the policy so seriously that they have integrated palliative care with cancer care or other specialty care subjects. For example, in the NHS, if you see, NHS has a strict rule of referring first to the GP then refers to the specialty person, and then the higher up hierarchy is something like that. But here in India, it is not like that. Our patients are free to go to a specialty doctor anytime. He's able to take medicines over the counter also. But having said this, the policy makers will need to understand the financial constraints that our patients face. It is also important for them to understand why this integrated approach needs to be taken. They also will have to understand the importance of home-based palliative care for our patients. So that is my take on that. There is a difference, but not much of a difference, because specialty doctors outside of India also have similar problems in not referring the patients to the palliative care physicians.
Okay, ma'am. Thank you for the clarification.
Thank you.
So I think we can go to the introduction to the course now. And if you have any questions, please type it in the chat. So this course, integrated course in palliative medicine, which includes both the basic and advanced lessons in palliative care. And this is planned over 12 sessions and live sessions. Plus, you have to log into the self-learning modules. And there are 33 modules which are text-based, and there are other few videos, I think 9 videos. And you are provided with a time schedule, and in which before each sessions, which all topics you have to complete is given in that. So before each session, you please complete those sessions, because otherwise you would not get full advantage of attending the class. The faculty will be speaking talking about these modules. So please complete all the modules before coming into the class. Okay, and I would like to show you the modules, how you can approach or how to log in into the self-learning modules. So Senior will be sending the details how to log in. So I am just logging into the so you have to enter your username and password. Then you have to log in. So you will get a screen like this, and you have to come to click on the form. Okay, then you will see only the two courses, the two on the left hand side. One is integrated course in palliative medicine session recordings and essentials of palliative care India. Okay, so essentials of palliative care India, it contains 33 modules on various aspects of palliative care. So before you enter into the module, there are some pre-test surveys which you have to do, and then you will be able to go into the first course, Introduction to Palliative Care. I'm not not going to show you the Introduction to Palliative Care because there are no assignments in that. But after that, every sessions, every module has assignments. So under pain management, you can see there are 14 modules. Then in symptom management, there are 5 modules. Communication skills, there are 6 modules, and dementia, there are 7 modules. So let me show you one on pain management. So you have to enter the course comprehensive pain management. Okay, it will be like this, and then you have to enter. So first it will be tools and resources session. So if you want, you can download this tools and resources, and then you have to click the next item. So there will be text like this. Okay, and in between these texts, there will be some questions which is not which will not be taken for assignment. This is just for you to see how or where you are standing. So when you submit, it will give you the answer, and there will be explanations. Okay, and yeah, you have to click. So you can see why does opiophobia exist in healthcare providers. You can complete that, and you have to also complete inpatient and family. Otherwise, this will not go down. Okay. So you have to complete each part of this. Then only this will move further. So these all are just click when you see the plus mark, just click on that to expand. Okay, and there are actually all these modules goes through case study, so it will be easier for you to understand it. So I am not doing this. Just want to show you. I have entered as an admin, so I'll be able to go to the next. That is not allowing me to go to complete this. So you have to note that if you do not get 80% marks in the module, you will not be able to go to the next module. So if you don't get 80%, then reattempt it. Then only you will be able to go to the next module. So another thing is that all of this module can take about 1 to 2 hours, depending on your level of understanding. So please plan that 1 to 2 hours for each module. I cannot say exactly 1 or 1.5 because it depends on your knowledge regarding the subject. So now I has come to the course post test. This is the assignment. Okay. So this is the first question. You can click the right answer and submit. It will show you the whether it is correct or not with explanation. Go to next. It is incorrect. Incorrect. So there will be 10 to 15 questions in each module. And you can actually do it according to your convenience because suppose you started a module and you have to stop in between before finishing the module, then you can log out, and when you next log in, it will automatically come to the place where you have stopped it. Then you have to continue it from there only. No need to come to the start of the module. So I have finished, and you can see your score. I scored only 20%. Passing score is 80%. So if it comes like this, then you have to exit the course. You can see which is on the right hand side upper corner. So I am exiting the course. Exit activity. So I will come back to this page where all the modules are given, and I have to again click on comprehensive pain assessment. Then you have to tick this box. Please check this box, start a new attempt. Then only the system will accept this as new attempt. Otherwise, even if you score 80% in this session, it will not accept. So please remember to check the box, start a new attempt, and then enter, and then you do continue what I have shown you. So this is how each module you have to go. Once you become familiar, or if you log in into this once, then you will understand it better. And you can also see that there are some recorded sessions. So that is an integrated course in palliative medicine. So these are the two modules which you will be able to access. Okay, there are this is a video. So if you click on that, it will open, and you can play it. Okay, and after this, there will be a few questions on ethics. So I have done it, shown it too many times. That's why it shows multiple items. So you can see there are a few questions which you have to check the right answer and finish the attempt. So this is how you have to enter into the self-learning module and complete the module. So if you have any problem in accessing these modules, and if you face anything about this in accessing these modules, please put a message in the group that has been created. Sini, I believe an IT person has added in this group.
Everyone is added in the group, sir, and the login credential has also already been shared with them in their mail.
No, I am asking whether Vishnu or Mahesh has been added into this group.
No, sir, we can add them.
Yeah, so one of our IT person will be added to this group. So if you put the message, they will give you, or they will tell you what to do in case if there is any problem. And from next session onwards, the first 1 hour, it would be 20 to 30 minutes presentation from the faculty side, and then you need to ask your doubts. So when you go through the modules, so maybe the next class would be after 10-15 days. So till that time you have to complete maybe pain modules 1 to 5 and medical ethics, I think. So you have to complete this, and so that you will have some doubts which you can clear with the faculty. And after 1 hour, one of the participants need to present a case history which is appropriate to the session that's going on. So if it is pain modules that or pain and ethics, it might be together. So if you have a patient story on either on pain or on medical ethics, you have to present a patient story. So everybody is requested to book their slot for presentation. Senior will be sharing the template for the case presentation. So you can just fill the template and send it to senior at least 2 days before the session. Okay. Anybody want to ask anything now? I hope all of you have logged in into the learning modules. So, Sini, I think you also need to send the website address.
Sir, it's already shared.
And only they will. Yeah. Okay. Anything else? Any comments or
Sir, sometimes it becomes difficult to attend the lectures because we would be in our emergency duty or something. So how to cope with that? I have a doubt.
senior? I think you have to attend at least 80% of the sessions. Out of 12, you have to attend at least 10 sessions. I would strongly recommend that you should attend all the sessions. But if there is any like emergency or something like that, then you may not be able to attend. So rest, we will take it on a personal chat. You can contact the coordinator senior and she will tell you what to do. And the recorded session link would be available. It will be shared with each of you. Anything else?
Sir, we have already close to the time.
Yeah. So thank you everybody for attending today's session, and we hope to learn together during the coming sessions. So thank you, Sanghamitra, for enlightening us with the meaning of palliative care and what to do, how to do, and how to deliver it, etc. Thank you very much for that beautiful session. And thank you everybody for your active interaction. Thank you.
Thank you, Sanghamitra madam, for the informative session, and thank you, Sunil sir, for the facilitation part. Thank you all for having the active session, and I would like to tell you that the next session will be on December 30th, same time. So we will be giving you intimations timely. Thank you all.
Thank you so much.